screen. Let's see. Can you see my screen?
Yes, I can see.
Is there any way that I can see you all still? Or no?
Yeah.
This is the first time I've done this on Zoom. Can you see my screen now or no?
No.
Okay.
I only see 3 of us.
All right.
Now I see the slide.
Okay. All right. So I can't see you all. So if you you're gonna have to like say something if you have a comment, because I don't think the chat thing is gonna pop up. Okay.
Yes. Okay.
All right. Sounds good. So today we are talking about acetaminophen and salicylate toxicity. Do you all call it paracetamol there?
Yes. We use a lot of paracetamol and salicylate.
Yeah. Okay. So this is super relevant. So I am going to warn you that I will probably call this acetaminophen or Tylenol because we don't call it paracetamol. So just so you're aware, when I say Tylenol, that's what I'm talking about.
Okay.
Can you see my mouse move or no?
Yes, I see.
Okay, perfect. All right, sounds good. Okay, so we'll talk about background, physiology, patient presentation, workup, and treatment. So in background, so acetaminophen or paracetamol, is an analgesic and antipyretic. It is available in single formulations, as we know, and also in combination with other drug classes like antihistamines, decongestants, expectorants, and opioids like hydrocodone, acetaminophen. It is the most common pharmaceutical poisoning exposure worldwide, and deaths from acetaminophen poisoning account for approximately 10% of all deaths that are reported to poison centers. Most of the deaths happen after a single acute overdose. And drug-induced hepatic injury is the most common cause of acute liver failure in the United States and Western Europe, whereas elsewhere it's viral hepatitis. So for physiology, Tylenol metabolism is important in the toxicity. So when it's ingested orally, Tylenol is absorbed rapidly by the small intestine. And then after absorption, it goes through multiple routes of metabolism. Most of it goes through glucuronidation over here. And then the next most goes through sulfation over here. And then a very small amount goes through oxidation through the P450 pathway. And it turns into this substance called NAPQI, which is toxic. So when we have therapeutic Tylenol levels, if we're taking the appropriate dose, only a small amount of acetaminophen goes through this oxidation pathway and is made into NAPQI, which is the toxic thing. And then our body quickly detoxifies this toxic substance. It turns it into this like substance that our kidney can excrete easily. So it doesn't cause us any issues. In Tylenol overdose though, this pathway up here and this pathway over here get super saturated because there's so much Tylenol. So then you have increased amount of Tylenol going through this pathway. So you get increased amount of toxic NAPQI. Your NAPQI is not causing an issue until this glutathione runs out, because glutathione is what detoxifies it. So once your glutathione store is depleted, you have toxicity. NAPQI is toxic because it binds to proteins in our liver and causes centrilobular necrosis, and so you get cirrhosis and hepatic failure. Interestingly, children are able to metabolize Tylenol more through sulfation, this side of the pathway, so then they can actually take a lot higher doses of Tylenol before they get toxic, because they go through more of this and less of this pathway. We really have to worry about Tylenol overdose in people that have already low levels of this glutathione. And those are people with chronic liver disease, chronic alcohol ingestion, and chronic malnutrition. So they're the people that you worry about chronic Tylenol overdose. So they could be someone you prescribe Tylenol to at a normal dose, and then they unfortunately have toxicity still. So for example, this case, a 40-year-old man, history of hepatitis C and alcoholism, comes to the ED with dental caries. A brief history and unremarkable physical exam is documented. The patient is discharged and fills his prescription for hydrocodone acetaminophen. And 2 weeks later, he dies of fulminant liver failure, and the family initiates litigation for your excessive acetaminophen prescription. So definitely keep this in mind. So how do we treat Tylenol overdose? The way we treat it is we give them glutathione. There is no way to actually give glutathione though, so we give them N-acetylcysteine. N-acetylcysteine right here gives this cysteine molecule that our body uses to make glutathione synthesis and repletion. And so now we can detoxify the NAPQI and we don't have hepatic failure. You all still following me?
Yes.
All right. All right. So how do these patients present? So they look very well, like this lady. They look fine. They have non-specific symptoms, and so we can miss potentially lethal ingestions. So the key is getting a really good history. We have to think of this in any overdose patient or anybody that has any psych complaint. When you get your history of possible overdose, you have to determine the time of ingestion, which is absolutely crucial. Also, how much did they take, and did they take any other medications with it, and are they having any symptoms? On physical exam, you really won't find anything. They might have some abdominal tenderness, but you can't rely on that. So clinical toxicity occurs in 4 phases. Stage 1 happens in the first 24 hours. Usually people don't have any symptoms. If they do have symptoms, it's nausea, vomiting, and their AST and ALT are usually normal, as well as their PT-INR. Then on day 1 to 2 is stage 2, and they have minimal symptoms, but then this is when you start to see the hepatic injury. So you might see a little elevation in their liver enzymes. Stage 3 is 3 days in, and then they are maximal hepatotoxicity. Their liver enzymes might be greater than 10,000. You might see altered mental status because of hepatic failure or renal failure. And their prognostication of eventual hepatic failure is does not depend on how high their liver enzymes are. Then stage 4 is 1 to 2 weeks later. And this is if the patient survives from the hepatic failure, then they get hepatic recovery. Death often occurs 4 to 5 days after an overdose because of multi-organ failure and liver failure. So your workup, you're going to do your usual overdose labs, but really make sure you get Tylenol level, AST, ALT, and PT-INR. The time of ingestion is super important to decide when to check your Tylenol level. So you have a patient come into the emergency department. They tell you they took Tylenol. You ask them, what time did you take it? If they tell you I took it 2 hours ago, then you do not draw your Tylenol level for another 2 hours because you cannot check your Tylenol level until 4 hours after ingestion. If you're going to use this Roux-Mathieu nomogram. So wait 4 hours, then check your level. If the patient does not know what time they took the medication, or if they're unreliable, then just check your Tylenol level as soon as they come in with all their initial labs. If they tell you that they took Tylenol more than 8 hours ago, but it was less than 24 hours ago, go ahead, check your Tylenol level with all your initial labs, but you also want to go ahead and give them N-acetylcysteine immediately before you even have your results. The reason is, well, I'll talk about it in a minute, but if your results then come back like an hour or 2 hours later from the lab and all your stuff is normal, Tylenol levels negative, LFTs are normal, then you can discontinue N-acetylcysteine. When you're interpreting like your, I guess, predicting your toxic levels, if you ask the patient how much they took, the magic number is 150. So potentially toxic dose is 150 mg per kg or 10 grams in adults. And then there's this really increased risk of hepatotoxicity with massive Tylenol ingestions, which makes sense. But the magic number to remember with Tylenol is 150. So potentially toxic dose, 150 mg per kg. You'll see 150 also on this Roux-Mathieu nomogram. So this is what we use in an acute ingestion if the ingestion is less than 24 hours. You have on the x-axis your hours after ingestion, and then the y-axis has your plasma concentration. So if you get your level at 4 hours, you go up and you can see that at 150, which is our magic number again, that is the treatment line, this red line. So if anything is at or above this line, that's when you treat them with N-acetylcysteine. So it predicts liver injury. It is not useful in a Tylenol ingestion that happened before 4 hours because your body hasn't absorbed the Tylenol yet. You can use a level between 2 and 4 hours after they took it, though, to like rule out exposure. But then you have to trend their levels. And then if they have a chronic ingestion, you don't use this at all. So let's talk about treatment. So if somebody comes in less than 1 to 2 hours after their overdose and they're awake and cooperative, you should give them activated charcoal. It might reduce the absorbed dose of Tylenol. And gastric lavage does not do anything for Tylenol toxicity. And N-acetylcysteine is our absolute key. It works, again, by repleting glutathione, so our body can detoxify NAPQI and we avoid hepatocellular necrosis. So when do we give NAC? In an acute ingestion, if your Tylenol level crosses that nomogram line, you give it. It's nearly 100% effective if you're giving it within 8 hours of ingestion. So that's why if your patient is coming in at that 8-hour mark, you just give it because the benefit outweighs the risk. Each additional hour of delay increases the risk of hepatotoxicity dramatically. So if the level is greater than 150 at 4 hours, you give it. And then chronic ingestions are an unknown time of ingestion. You cannot use the nomogram. So you give N-acetylcysteine unless you get their labs back, their Tylenol is undetectable, and their liver enzymes are completely normal. It comes in oral and IV formulations, and these are equally efficacious. The problem with the oral N-acetylcysteine is that it smells and tastes like rotten eggs, and so your patient is probably not going to be compliant with taking it. You can also see anaphylactoid reactions with N-acetylcysteine, and they're not typically life-threatening. They usually have itching and urticaria, and it resolves with symptomatic therapy with diphenhydramine, and then you need to decrease your drip rate. You can see severe reactions, but they're rare. So how do we dose this? Again, the magic number is 150. So this below is like the whole protocol, which I will never remember. So in the emergency department, I think this is the important thing for us to remember. If you're doing IV, you give 150 mg per kg. If you're doing oral, you do 140 milligrams per kilogram. And then you can look this up later or send them to the tropical medicine floor. So alternative therapies, fomepizole has been used in massive acetaminophen poisonings, but data is unclear, so don't give this unless a toxicologist is telling you to. And then hemodialysis, so Tylenol is dialyzable, but it usually is not done because N-acetylcysteine works so well, and it's only usually done in severe acetaminophen poisoning. You have to consider liver transplant early and transfer them to a facility that is capable of that. You can use this King's College criteria to decide who needs a liver transplant to try to predict it. But again, this is probably what the tropical disease toxicology doctor's doing. Disposition, if you have a patient that has a Tylenol concentration less than 150 or below that Rumac nomogram line, and their liver enzymes are totally normal, you can discharge them home. You don't have to give them any N-acetylcysteine. Obviously, you have to think about like their psychiatric stuff and consider, are they suicidal, but you could still discharge them. Anybody that's requiring N-acetylcysteine, you have to admit them because they will need repeat lab work in like 24 hours and they'll need to continue that infusion for 24 hours. All right, so any questions before we go on to the next topic? Oh, how to predict liver damage earlier? Is that the question? So yeah, what I found was this, the King's College criteria. So it's a method to predict the need for hepatic transplant. Really? You can't check a Tylenol level? What do you do? Oh, really? Do you just give an acetylcysteine just in case then?
Maybe we just give them the acetaminophen when we see that they have the hepatitis.
Yeah.
Yeah.
Yeah, maybe just give it and then send the level, and maybe the level comes back in a day or something, if possible. Transfer them to Chore. All right, so we'll go on to salicylate. I'm going to lose the chat again. So if you have a question, just yell at me. I wonder if this is going to go to the beginning. Okay. All right, so now salicylate overdose. So we're going to do background, then patient presentation, pathophysiology workup, treatment. So background, salicylates are in aspirin, Pepto-Bismol, like this medicine down here for your stomach, methyl salicylate, oil of wintergreen, Excedrin migraine medication, topical ointments like sports creams, and most importantly, Tiger Balm. I saw so many people snorting Tiger Balm. I think everyone is addicted to it. So it's analgesic, anti-inflammatory, and has antipyretic effects. I thought this was very interesting. So in 2007, this was a USA News article. So Ariel Newman, high school track star, suffered from typical aches and pains that results from a grueling training regimen. For relief, she covered her legs with large amounts of muscle cream. The 17-year-old died from an accidental overdose of methyl salicylate, the wintergreen scented ingredient found in liniments like Bengay, Icy Hot, and Tiger Balm, like this Bengay. So very relevant. So the background, so toxic dose is greater than 200 to 300 milligrams per kilogram. Potentially lethal dose is 500 milligrams per kilogram. So these are like questions that might be on an exam. Your concentration does not always correlate with signs and symptoms. And your toxicity can be acute or chronic, similar to Tylenol. The chronic toxicity is actually associated with a higher mortality due to delayed diagnosis because they have vague symptoms. They are usually older patients, and so they have more underlying comorbidities. So how are patients presenting? I'm starting with patient presentation because the pathophysiology and the metabolism is really complicated. So I think it's easier to think about how they're presenting and then think about why they're presenting like that. So the Tylenol overdose patient looked fine. This patient looks like crap. They look super sick. They're in this like hypermetabolic state. So they look like a patient with DKA or like someone with sepsis. They're tachypnic, hyperthermic. They have lactic acidosis. There may be tachycardic, altered, etc. So how are we going to diagnose them with salicylate overdose when they look like everything else? So this is like an example of how vague they can be. So a 49-year-old woman found at home by her daughter, confused and lying on the floor in her own vomit. EMS was called, and during transfer, paramedics noticed a declining mental status. On arrival to the ED, the patient had a Glasgow coma score of 6 with the following vitals. She has a fever, she's tachycardic, her blood pressure is normal, respiratory rate is 15 breaths per minute, but she's intubated. Oxygen saturation is 98%. Upon return of the VBG, her pH is 7.25, PCO2 is 17, bicarb 10, venous excess negative 11. So how do you make this diagnosis of salicylate overdose? Because you could say this lady is probably septic, she's febrile, she's tachycardic. Maybe she has like meningitis, encephalitis, she's altered with a fever, etc. But the key is in the blood gas. She has a really low PCO2, so she has a respiratory alkalosis from hyperventilation, and she also has a metabolic acidosis. So that's going to be our key. So patient presentation, salicylate toxicity has no unique physical exam findings, but you could see like tachycardia, tachypnea, hyperpnea, hyperthermia, nausea, vomiting, abdominal pain, tinnitus, hearing dysfunction, coma, seizures, altered mental status, hallucinations, pulmonary edema, acute respiratory distress syndrome, and diaphoresis. So why do these things happen? Again, the metabolism is super complicated. So I'm not going to go into all the details, but basically it stimulates our medullary respiratory center. It inhibits cyclooxygenase, and it uncouples mitochondrial oxidative phosphorylation. So step by step, it activates medullary respiratory center. It activates our brain to cause hyperventilation. So therefore, we get respiratory alkalosis. It also uncouples oxidative phosphorylation. So if you guys are like me, I don't remember what this is, and it's like nightmares from medical school. But in the most simple terms, oxidative phosphorylation is how our mitochondria make ATP. So salicylate is stopping this from happening. So our mitochondrial respiration is becoming more inefficient. We are now having aerobic respiration rather than aerobic respiration. You have like all this energy built up that is not being able to be used. So you generate some fever. Then this uncoupled oxidative phosphorylation, again, means you have anaerobic respiration rather than aerobic. Elevated lactic acid because of the anaerobic respiration, and so you have an increased anion gap metabolic acidosis. Salicylates also cause fatty acid metabolism, similar to like DKA, so you get ketosis. So your body's making all these ketones that further worsens your anion gap metabolic acidosis. So underlying thing, respiratory alkalosis with metabolic acidosis. So how do we treat these people? The key to treatment is to alkalinize and dialyze. So sodium bicarbonate is how we will alkalinize them. The reason this works is when your blood is acidic, aspirin is in this form, ASA. ASA can cross the blood-brain barrier, and then you get cerebral edema, seizures, and death. But when our blood is alkaline, aspirin becomes negatively charged. And this negatively charged molecule is not able to cross our blood-brain barrier. And it is actually stuck in the kidney. So it's excreted in the urine due to ion trapping. So the ion gets stuck in the nephron, and that ion does not allow your body to reabsorb it from your kidney. So you have to urinate it out. That's why this works, and alkalination is the key to treatment. So we have to check a blood gas and a urine pH, and our goal blood pH is 7.45 to 7.55. Our goal urine pH is greater than 7.5. We're going to give a bolus of sodium bicarb, and then we will start a drip, and there's your doses. We have to watch for hypokalemia as we make the patient more alkaline, and we have to replete potassium aggressively because hypokalemia can limit this urine alkalinization process. So our next key in treatment is hemodialysis, and you're going to dialyze patients, any patient with these indications. So CNS involvement, worsening acidosis, rising salicylate level despite giving them sodium bicarb, renal failure. If it's an acute ingestion, your key number is a level greater than 100. If it's a chronic ingestion, your key number is greater than 50. If they have any pulmonary edema, and then most importantly, we have to look at the patient more than these numbers. So that's really what determines hemodialysis or not. We also give activated charcoal. So if they come in within an hour of ingestion, you should give activated charcoal to reduce the absorption. And then also, so salicylate does this weird thing called forming bezoars, which is basically this big glob of salicylate. It happens more so in enteric-coated products. So all these tablets clump together in this big lump, and they get stuck in your patient's GI tract. So they can get intestinal obstructions from it. But the reason that you'll know or you'll think of this like bezoar is because you have a patient that has a salicylate overdose, you check a level and you're giving them sodium bicarbonate, you're treating them appropriately, maybe you're even doing dialysis, but their salicylate level keeps going up despite your treatment. And the reason is they have this big glob and your body's continuing to absorb it. So you have to talk to like a toxicologist about do I give them multi-dose charcoal? And then also sometimes even gastroenterology goes in and does endoscopy and takes out the big glob of salicylates. Other things to think about is we'd like to avoid intubation if possible, because we are going to take away that respiratory alkalosis, which will worsen their acidosis and make them more toxic and make that cross the blood-brain barrier even more. So if you have to intubate them because they're altered, then you just want to use high-minute ventilation. You also want to keep their glucose on the high end of normal because salicylate does this weird thing called neuroglycopenia. So their brain can have low glucose levels and you have no idea because they're their blood glucose level looks normal. And that's like very detrimental to their prognosis. So disposition, we can discharge any patient that is asymptomatic with a normal anion gap, salicylate level less than 30 after serial lab draws, and normal pH. And then anybody else, you admit them, and if they have really bad toxicity requiring hemodialysis or anything, you admit them to the ICU. So I will pause. Any questions before we go on to the questions? Are you able to check salicylate levels?
I have never done it before. I don't know. Because most of the patient come and we didn't think about the salicylate overdose.
Yeah.
Yes.
Now you will.
Yes. We often think about the lactate acidose or sepsis more.
Right. Yeah. So we have to, it has to be on the differential of anybody that we are thinking DK or sepsis or anybody that's sick. All right. So let me go back to this and we will go over the questions. Where am I going? View. All right. So you're going to have to yell at me because I can't see your faces or the chat box. So these questions I think are really they're helpful to go through cases because I don't know. I think Tylenol and salicylate things can be kind of confusing to remember because there's numbers you have to remember and stuff like that. Okay. So 18-year-old woman states that she has ingested 50 capsules of acetaminophen in an attempted suicide 4 hours prior to arrival. Her mother confirms the time of ingestion. Her serum acetaminophen level is 100. What is the most appropriate next step in management? What do you all think?
I think it's B.
D? Is that what you said?
B.
Okay, B. So the answer is actually D. The reason is that you're checking her level at 4 hours and her level is 100. And remember that in acetaminophen, this is why I want to do these cases because it's confusing. So acetaminophen, the level is 150 at 4 hours. So you get your level, you come to this little nomogram, you see 4 hours, you trace it up, and her level was 100 right here. So she is only right here. She's below that red line. And so she does not need anything. And she gets to go home after psychiatric evaluation. But you don't give N-acetylcysteine. Yeah.
But I have a question. What if we just give her acetaminophen? What if? Because most of the AD department they don't have paracetamol
level. Yeah. So I think in that case I would give her the N-acetylcysteine for sure. So yeah, I think if you don't have a level and you don't know what her level is, and I mean she's telling you she took quite a bit of acetaminophen, right? 50 tabs. So I agree with you that I would give her N-acetylcysteine. In this question though, you have the number, so the answer is supportive care and psych eval. But real life, I agree with you. I would give her N-acetylcysteine. All right.
But is that something will harm the patient?
So no, not necessarily. I mean, the side effect of N-acetylcysteine that can happen is that you can get that anaphylactoid reaction, but it's not going to happen in everyone. That's just the most common side effect from it. But it's not I have never seen that happen, and I've given N-acetylcysteine a lot. because like during COVID, I don't know if you all saw this. I know you don't see pediatric patients there really, but during COVID, I saw so many like teenagers overdose, try to commit suicide because they were like so depressed from being stuck at home and not being able to go to school. And so I gave so much N-acetylcysteine, it was crazy. And I never saw that anaphylactoid reaction. So I definitely think that the risks like are very low compared to the benefit of not liver failure.
Thank you.
Yeah. Yeah. All right. Next question. So a 35-year-old woman with a prior history of suicidal ideations is brought to the emergency department approximately 10 hours after ingesting an unknown quantity of acetaminophen and ibuprofen. She is complaining of nausea and heart rate is normal, respiratory rate, all vitals are fine. Physical exam reveals diffuse abdominal pain. What is the most appropriate next step in management? What do you think?
Yeah, I think it's D. Or D, maybe.
So no, it's actually B. Again, this is why I wanted to go through this because these are
we
super
don't
confusing.
have paracetamol level.
Right. So because she is coming in 10 hours after taking Tylenol. So that is after 8-hour mark. So yeah, we're gonna give her N-acetylcysteine. We are gonna check the level, but the first and utmost important thing for her is to give her N-acetylcysteine because she is after 8 hours.
8 hours.
Yeah. So the risk of severe hepatotoxicity increases if the patient is not treated with N-acetylcysteine within the first 8 hours. And every hour you delay it, the hepatotoxicity like shoots through the roof. So if your patient comes in after 8 hours, you give them N-acetylcysteine at the initial dose of 140 oral or 150 IV without delay, and then like order your Tylenol level as well as all your other lab results, but do not delay therapy while waiting on the results.
Okay.
Okay. Any questions about that?
Yeah, it's okay.
You're saying labs come back and everything's fine, her Tylenol level's negative, her liver enzymes are totally normal, then you just stop the N-acetylcysteine. No issues. But at least you did your due diligence and gave them the medication right away. Or again, if we can't get a level, just give it. All right. A 34-year-old man presents to the emergency department due to an intentional overdose. He wants to kill himself and took a handful of acetaminophen tabs about an hour ago. Which of the following is a sign or symptom associated with early, less than 24 hours acetaminophen overdose?
I think it's D.
Yeah, D. So early in toxicity, symptoms are vague and include malaise, anorexia, and nausea. And then day 2, you can get hepatotoxic signs like right upper quadrant tenderness and pain. And then you get fulminant hepatic failure 3 to 4 days after ingestion. And then in really bad overdoses, you can see renal failure, altered mental status, severe lactic acidosis. All right. A 4-year-old boy presents to the emergency department unresponsive following an unknown ingestion. His arterial blood gas results include pH 7.2, CO2 20, and bicarb of 12. Which of the following is likely the cause of his symptoms?
Let's see. Maybe see.
Yeah. So oil of wintergreen is a highly potent and concentrated form of methyl salicylate. And this is pretty crazy, but 5 milliliters of the oil has 111 tablets of aspirin equivalent. So a tiny amount is deadly to a child. Yeah. Tiger bomb. All right. Which of the following is an indication for hemodialysis following a salicylate overdose? Serum salicylate level of like which of these? I'll give you a second.
It's B.
Which one? Sorry.
B.
B. Yeah. B as in boy. Yep. So greater than 100 following an acute ingestion. And then, so for chronic ingestion, it's 50. All right. And the last question. A 24-year-old woman is brought to the emergency department after a suicide attempt. She took 30 tablets of an unknown drug 4 hours prior to presentation. She is obtunded on presentation and is breathing rapidly and deeply. An arterial blood gas is performed and results include pH 7.2, CO2 20, and bicarb 15. Which of the following agents is indicated in the treatment of this patient?
Yes, it's the sodium bicarbonate.
Exactly. So we have to alkalinize her. So goal serum pH around 7.5. We're going to bolus her sodium bicarbonate and then continuous infusion. And you can put like 3 amps of sodium bicarb in a liter. And then make sure you add potassium so that you're preventing hypokalemia because that will worsen your acidosis. And that is the end.
Thank you, Shirley.
Yeah, no problem.
Yes, you give me a useful information about salicylate acid overdose, and I will remember this.
Good. I'm glad.
It's helped me a lot.
Good, I'm glad. All right. Anything else?
Yes, a lot of green oil.
Everybody's smoking it.
It go green oil a lot.
Yeah.
Yes. I use a lot of green oil and the abdomen pain also.
Yeah.
Okay.
All right. Well, I guess I'll see you all next week.
Yes, thank you.
See you. Right. Yeah, sounds good. All right.
Sounds good.
Bye.